So it's a family of mom, dad, and 3 sibs. So, and 3 of them were affected with mutations in IKAROS. And the clinical phenotype was familial form of autosomal dominant CVID with pediatric onset or adult onset with progressive B-cell lymphopenia. And here's the first tip. B-cells decline could be progressive. So a single test might not suffice. You might have to test multiple times to see if the B-cells are declining. Severe hypogammaglobulinemia that is also is progressive, poor antibody response, and high CD3 and CD8 T cells. And clinically speaking, the patient behaved as most of the CVID patients that they have hypogammaglobulinemia. They have recurrent bacterial infections, including pneumococcal meningitis and sepsis. Now, this is the mutation that we found in this particular family, and this is what we published. So mutations can come in different flavors. So they can come as missense mutations, or they can have like intragenic deletions or multi-gene deletions. So what I mean is here, the model that we're going to describe is single allele mutations. So whenever you find a single allele mutation, pay attention in IKAROS because they can have in multiple flavors: missense, intragenic deletions, or multi-gene deletions. About the clinical phenotype, most of the patients have low B cells, approximately 1/2, and almost all of them fulfill the criteria for CVID, that they have 2 isotypes of immunoglobulins that they are low. In those patients that we tested, the antibody function, it was poor. Infections are the ones that we usually see in patients with CVID, strep pneumo, Haemophilus influenza, and then some others that are probably related to other comorbidities. For example, this patient with M. cheloneae, Mycobacteria cheloneae, so it's a patient who was associated with a bone marrow transplant. C. difficile was associated with a patient that has a lot of antibiotic pressure. So as most patients with CVID, so you can find that they have autoimmunity, and ITP was present in 1 of 29. BALL, so it was present in 2 out of 29, and 1 patient has been transplanted because of the BALL. And interesting enough, you will find patients in the same family that carry the same mutation and might not have clinical manifestations. If you study their immune system, they're going to be immunological penetrance, but there might not be clinical penetrance. Keep this in mind, that if you can find individuals with mutations in IKAROS and in the same family, do you find other family members carrying the same mutation but without symptoms, it doesn't rule out the presence of the disease, because this disease has incomplete clinical penetrance. Approximately 1/3 of the patients that they carry mutations, they may not have clinical manifestations. But let's go to some area where you all might feel more comfortable, and it's kind of the testing. As you can see, and I told you before, the hypogammaglobulinemia is progressive. So we study patients before they were symptomatic, because one of the mom insisted to study them, and we can track that they are born with normal levels of immunoglobulins and the levels go down. So if you find a patient with a mutation in IKAROS and they have normal immunoglobulin levels, that doesn't rule out the disease. Just keep on following those patients because IgG can go down. Same thing with the B cells. They might be normal at the beginning at early ages, but then they might decline. Actually, we had patients that had their first manifestations in their 40s, 50s, and 60s. So again, having somebody asymptomatic by age 20 doesn't mean that they're gonna remain the same way during their whole life. So IgG and B cells are progressively declining. Interestingly enough, all those B cells, they're memory B cells, they're CD27 positive. So even they're very low, so they're memory B cells. So in terms of T cells, CD4s are normal, and CD8s in a subset of patients, so they can be high. I can explain you later why, but if you see a combination of no B cells and high CD8 cells, that's gonna be a good hint in order to suspect IKAROS deficiencies. If you go to the bone marrow, you can see that the arrest is very early. Here you have the control bone marrow. Here you can see the patient bone marrow. You can see that a significantly decrease in immature B cells and also pro B cells. You can see how low they are compared to a healthy control. And if you go to the most early stages of B cell development, you can see that the B cell progenitors, pre-Pro B cells, are markedly decreased. But again, whenever the very few cells they make it, the kappa lambda distribution is normal. And actually they can make it into memory B cells. So what it means is the arrest in B cell development is very early, but the few cells that they make it the full way. And actually they have a normal kappa lambda distribution. Actually, also when you go into the bone marrow, you can see here C34 and 138. So those are pluripotent stem cells, and those are plasma cells. Here you have a healthy control. Here you have a typical CVAD patient. Typical CVAD patients, they lack plasma cells in the bone marrow. Our patients, they do have it. Why? Because they used to have normal B cells at the beginning that they make it the full development. So those B cells, probably they are long-lived B cells. So if you look at the bone marrow, think that these patients, despite of being CVAD, they might have plasmablasts and plasma cells in their bone marrow. So in terms of the biology, I will not go into too much detail because this is completely related to research, but those mutants, so the ones that they were missing, they are able to dimerize with the wild type, and we were looking about the binding to the DNA by the EMSA. You can see that the mutants by themselves, they couldn't bind. And actually, most of the time, they were not exerting a dominant negative effect compared to the wild type. So it was a haploinsufficiency model, the one that we thought. And that was confirmed by another experimental data. Here you can see we transfected cells with the wild type or with the mutant. Here you can see when we transfected the cells with the wild type, it was this dotted pattern. That is the one that we expect with wild type IKAROS, and you can see that the mutant could not bind to the DNA to the pericentric heterochromatin. So this mutant doesn't follow the normal pattern of binding to the DNA. But this is not the biological situation because our patients, they have one wild type and they have one mutant. So then we co-transfected cells with the wild type in red and the mutant in green. And you can see that we can still see those dots, even there are fewer dots here than here. So, but it was not exerting a dominant negative, the mutant over the wild type. So that's why we conclude that CVAD model was related to the haploinsufficiency model of mechanism of action, patients that were progressively losing their B cells, progressively losing their immunoglobulins, and their B cells, they were all mature memory B cells. But this is not the only model that we have shown and we have described associated with IKAROS mutation. So here is a completely different clinical phenotype. This is a patient that was referred to us because she had pneumocystis jirovecii pneumonia by the age of 10 months. So that was her first infection. It was very severe. And at that time, an immunological evaluation was conducted. And besides the PCP or PJP, that it's typically associated with a T cell problem, so she was found to have severe hypogammaglobulinemia with no B cells and normal high CD4 and CD8 cells. So at that time, the patient was rescued thanks to therapy with Bactrim, and he was placed on IgG replacement just to replace the B cell, not just to replace the B cells and the hypogammaglobulinemia, and also Bactrim prophylaxis to prevent pneumocystis jirovecii. She was doing great until the age of 2 years, where she started adding other clinical manifestations. Besides what we suspected was a T cell defect because of the pneumocystis jirovecii and the lack of B cells, the patient started adding myeloid defects. The patient started presenting with neutropenia, not severe neutropenia. It was in the 500, 700, but it was neutropenia as well, and also eosinopenia. So the patient had no eosinophils. So we didn't know that what that meant, but you said, okay, that's an interesting finding. And again, something that you can suspect that use as a clinical tip in order to follow these patients. So if you have patients with no B cells and no EOS, so, and also with neutropenia beyond the age of 2 years, keep that in mind that that could be one of the different forms of IKAROS mutations. So the mutation here was not that far From the other ones, it was at the same finger too, at the DNA binding domain. And we had mutations in 162 that were haploinsufficient, but this mutation was very particular. And actually, we saw it multiple times. So actually, this same amino acid, the asparagine 159, was mutated de novo in 7 individuals in 7 families from multiple continents. So this is a hotspot. So this particular site in IKAROS could be mutated at different sites, and these guys, they are not related one to each other. So it's always the same amino acid, N159, that can be mutated to a serine or to a threonine. But clearly the N is very sensitive to DNA changes. And actually, as I told you before, so we have 7 families, 6 of them with a serine instead of an asparagine, and 1 with a threonine instead of an asparagine. In 6 that we were able to test the parents, so they were de novo, and all these changes were private, and it was very clear that the cat was pretty high. So in terms of the clinical manifestations, this disease is not like a CVID. These patients are sick from the get-go. So among the 7 patients that we described, 3 of them were symptomatic before the age of 3 months, and all of them were symptomatic by the age of 15 months. So clinical manifestations are very early in this form of the disease compared to the other one that it can wait until the age of 40, 50, and 60. So the CVID, it could be manifest as an adult form of CVID or pediatric. This one is a combined immune deficiency that starts pretty early. Low B cells that are almost absent in all the patients that we know. Complete AGAM was almost the rule. Everybody was AGAM. IgE was very low in everybody that we tested. Actually, so we say here 5 out of 6 because one patient had a 1 international unit that at that time was kind of normal for age, but it was very clear that it was panhypogammaglobulinemia, lack of B cells, neutropenia, and eosinopenia. Think about those things as tips to diagnose these diseases. PCP or PJP was present in all our patients, but on top of that, they have severe bacterial infections like strep pneumo, Pseudomonas, Klebsiella, viral infections, RSV, adeno and herpes. So adeno and RSV took our patients to the ICU and they needed mechanical ventilation. Other fungi besides the PJP, Candida and Aspergillus, 4 out of 7. So clearly, this was a very severe disease, not like the other one that's just an antibody deficiency. So crypto was found in one of our patients and had sclerosing cholangitis that unfortunately took the patient to death despite the bone marrow transplant. TALL, again, cancer associated with IKAROS, and HACT was conducted in 3 out of 7 patients. Now 4 out of 8, all of them did well except the patient that succumbed due to cryptosporidium sclerosing cholangitis. Here, no asymptomatic individuals. Again, the clinical phenotype can tell you and can suggest you about the genotype of the patients. These guys have a combined immune deficiency. PCP, PJP is a very common manifestation. But what about the lab things that you are the ones that they are more interested in, and it can help you to diagnose these patients? Look at this. Here we are looking for naive central memory, effector memory, and temporal cells. Here you have the healthy control. Here you have the patient. Here you can see that the patient has most of their cells that they are naive on temporal. There are almost no central memory or effector memory cells. So very clearly the cells were markedly naive and not all the other subtypes. If we're using markers instead of CD45 array and CD62 ligand, we're using 45 array and a row. Again, most of the cells were array positive, although with a lower density of array. But you can see there's almost no arrow positive cells. Again, naive were very prevalent, And look here, we were looking at recent thymic emigrants. All the cells, okay, 96.1% of the cells, they were recent thymic emigrants. So those cells were recent thymic emigrants, they were naive, and they kind of stay there. And I will show you an experiment that shows that. But these are tests that you can do in your facilities. And so yes, these guys behave as a severe combined immune deficiency, and all the cells were naive and recent thymic emigrants, but they are not working very fine. in terms of T cell commitment, you can see here we are looking for interferon gamma as a marker for Th1. We're using an IL-4 as a marker of Th2, and we're using kind of IL-2 as the marker of Th0, and that was the only one. And you can see that the patient has most of the cells were Th0. So they have very few Th1, very few Th2. Also, Th17 were reduced and Tregs were reduced. So in a way, those cells were recent thymic emigrants, they were naive and they were Th0. All the cells were like that, and that could be a good tip in order to diagnose patients with IKAROS mutation with this particular allelic variant. And I was telling you before that those cells were naive, but they were not just naive. They were naive and they were unable to mature. Here, in vitro, we tried to mature those cells, and here you can see the controls. We stimulated the cells with PHA during 10 days, and you can see cells that they were naive and how the number of naive cells in the controls were going down. In terms of the patient, they were only slightly going down, and despite all the stimulation that we applied to them, they stayed with their naive markers, and you can see here they didn't acquire any memory markers. So while the controls along the time they were acquiring memory markers, the patients do not. So they were Th0, they were naive, they were recent thymic emigrants, and they couldn't evolve into memory cells. They were naive and they wanted or they couldn't move from their naive stage. And actually they didn't acquire any memory markers. So this is another tip for the diagnosis of this disease. So you are looking for cells that they are naive and they stay naive despite what you do in vitro to stimulate them. So we check, and this is more at the research level. We did RNA-seq at the T cells and also at the monocytes. So just to discriminate the lymphoid compartment from the monocyte compartment, as you can see here, the patients, so they have affected the T cells differently than the patient with the CVID variant. And as you can see, they have affected the monocytes different than the healthy controls and the patient with the CVID variant. So this disease, this allelic variant or form of the disease, not only affected B cells, it also affected T cells and it affected monocytes. And then you remember that the disease we described before, I told you that the disease was kind of haploinsufficient. The mutant that was not binding to the pericentric heterochromatin, so in this case, was very similar to the previous one. But when we put them together into the same cell, now the mutant was preventing the wild type in order to make the pericentric heterochromatin dots. So now it was not just a matter of haploinsufficiency, now it was a dominant negative effect. So here, so we have a different clinical phenotype and also a different mechanism of action. This is more research-wise, but we have enough tips from the general lab that can help us to diagnose this patient. But now we have a different clinical phenotype, a different mechanism of action. CVID was associated with haploinsufficiency, combined immune deficiency was associated with the dominant negative. The mutant was preventing the wild type to bind, and then we don't see any dots as we can see here. But then there's other clinical phenotypes, and this one was associated mostly with hematological diseases. So these diseases were malignant and non-malignant hematological diseases. This was a patient that he was healthy until the age of 9 years old when he developed disseminated Burkitt lymphoma. He had abdominal, kidney, and CNS involvement. He received chemo and he responded pretty well. 3 years later, he had the lymphadenopathies and ITP, so thrombocytopenia. So we're all very concerned that that might be the lymphoma coming back, but actually we biopsied everything and nothing was found. Actually, by the age of 13, he added more and new forms of autoimmunity and immune dysregulation. On top of the ITP that recurred, the patient developed neutropenia. And both those cytopenias, they responded to steroids, to MMF, and to sirolimus, and infections was not a big deal before the Burkitt lymphoma or after the Burkitt lymphoma. So this clinical phenotype, again, was distinct from the other two, the CVID or the combined immune deficiency. Infections here were not that prevalent, but the hem manifestations, either malignant or non-malignant, they were an immune dysregulation, they were highly prevalent among these patients. So the mutation now that we found in this individual was not at the DNA binding domain, was at the dimerization domain. So here it was probably another mechanism of action that was involved in the pathophysiology of this disease. And now, instead of having 7 families, 6 families, now we had 4 families, but we had 13 mutated individuals with also missense and null heterozygous germline mutations. So you can see, and they're mostly concentrated, they're mostly concentrated here at the DNA dimerization. They're stop codons, or just they have a stop codon after the most important DNA binding zinc fingers. 2 and 3 are the most important. Zinc finger 4, it has a relative role in terms of DNA binding. But the patient that they have a mutation here, it remove or devoid the protein of the dimerization domain. So clinically speaking, because again, the clinical phenotype can help you to suspect which are the mutations that they're underlying the clinical phenotype of your patients, the onset could be variable, like the CVID, it could be childhood or adulthood. Thrombocytopenia, ITP, was present in 3 out of 13. Autoimmune hemolytic anemia and Evans syndrome was present in 2 out of 13. Again, if you have a pediatric patient with Evans syndrome, think that you are in front of a genetic disease. So Evans syndrome per se is strongly associated with different forms of primary immunodeficiencies. Neutropenia, 1 out of 13. Absent B cells, 1 out of 13. Hypogammaglobulinemia, 5 out of 13. But keep in mind that the hypogammaglobulinemia here was mild, was in the 500, 600. It was below the 95% interval confidence, but it was not severe hypogam. It was just a mild hypogammaglobulinemia, usually with not too much impact in the clinical picture. Actually, so infections were recurrent but not severe in 2 out of 3. So 1 patient had recurrent sinusitis, 1 patient had 1 pneumonia. So infections, for reasons that we not fully understand, they were not the main feature associated with this form of the disease. But again, so the hematological manifestations and the immune dysregulation or the cancers were the one that they were kind of highly prevalent. Irritable bowel syndrome, colitis, thyroiditis, and pernicious anemia, highly prevalent. So benign lymphadenopathy was present in 1. TALL, 1 out of 13. Burkitt lymphoma, 1 out of 13. So 2 out of 13 patients have hematological cancers. And again, 1/3 of our patients that carry the mutations, they didn't have any clinical manifestations. But again, it's gonna be the long-term follow-up that are gonna tell us it was incomplete penetrance or just delayed onset of the clinical manifestations. So when we study these patients, there was nothing too much in terms of the study of B cells and immunoglobulins that I haven't told you before. So here are gonna be mostly research studies that can help you to sustain the diagnosis. So here we're doing co-IPs, and you can see here that the mutants were not binding to the wild type. So it was a dimerization defect. Yeah, it could be complete, like for more of the mutation, or partial, like for this R502L. So they were not binding together, they were not making dimers. And that happened IKAROS towards IKAROS, or IKAROS towards Aiolos, or IKAROS towards Helios. Again, they were defects about the dimerization. So because the protein didn't dimerize very well, so that prevented the protein to be stable. So then there was a protein instability that affected all the mutants in the same way. So because they couldn't dimer, that prolongs the half-life of the protein, so they couldn't. And also whenever we're looking at the DNA binding, those mutants that they were unable to dimerize, they were binding to the DNA as monomers. So this is a very detailed thing that it will not help to the clinical diagnosis, but it helps us to understand the biology of the disease. They cannot bind as dimers, but they can bind as monomers. And again, we study other things regarding those patients, especially how they were working. And the thing is, as I told you in the first slide, IKAROS work not by itself, but through different molecules that they remodel the chromatin. So, and those are the PRC the polycomb repressor complex, the NER complex, the nucleosome remodeling acetylase, and part of that is the HDAC complex. And all the mutants have dysregulated binding to the HDAC. It could be reduced or it could be increased, but it was never normal. So it was clearly that all those patients, they have abnormal binding to the molecules that they help make their actions, even the HDAC or the NER complex or the SYN3 or the polycomb repressor complex 1. So here you can see again that the wild type was binding, but the mutant, most of them, they were not binding to the pericentric heterochromatin. And when we're doing the co-transfection, you can see that the dots here, they're not yellowish like here, they're orange-red, because the only ones that they can dimerize are the ones that they are the wild type, because the others cannot dimerize. So, but they also could bind as monomers. So clearly the mechanism of action here was different, and it was based on the dimerization defective mechanism. And then we have another clinical phenotype that was completely different than everything that we have spoke so far. So we have another patient that was a 40-year-old patient with a lot of atopy, autoimmune thyroiditis and hepatitis, lymphadenopathies, normal B cells that were actually normal high with high CD21 low, hypergam, hyper IgE with normal low CD3, CD8 cells and eosinophilia. So clearly these patients were very different at all that we have described, but more interestingly, were exactly the opposite of the dominant negative. So remember the dominant negative, the one that was in light blue, that they have eosinopenia, they have agam, these guys have hypergam, these guys have elevated Ig, the other patients have no Ig. So clearly, so this set of patients, they were very distinct from all the other IKAROS variants, but especially they were kind of the opposite of the dominant negative. And the clinical phenotype, while on the dominant negative, those patients have a combined immunodeficiency, severe combined immunodeficiency. Here, the prevalent or the most obvious phenotype was immune dysregulation and autoimmunity. So autoimmunity because they have a lot of autoimmune autoantibodies and atopy and lymphadenopathies and normal to high B cells and hypergam and elevated IgE and eosinophilia. It was a kind of immune dysregulated clinical phenotype. Now the mutation is not that far away from the previous mutation. So here it's R183H. We found another mutation that's R183C, but it's again at the DNA binding domain. And if you can perhaps predict at that time, I told you that this one, the light blue, was dominant negative, and it has agam, no B cells. These guys have hypergam, high B cells. So if this one was dominant negative, we predicted that that one was likely to be gain on function. And that was the case, and I will show you soon. So now we have 4 families that were carrying the same mutation. So, and you can see 3 of the families were carrying the 183H. They were coming from all continents. They were coming from Japan. They were coming from France. They were coming from the US. And this is another family that has another mutation at the R gene in position 183, but instead of having an histidine, has a C at position 183. So again, 8 affected individuals, 1 likely de novo, 1 asymptomatic. Again, we're finding patients that carry the mutations and they didn't have clinical manifestations. And here is the mechanism of action. You can see here the wild type. Here you have the EMSA, and you can see that at certain level, the wild type stopped binding, but the mutants were binding to the DNA increasingly compared to the wild type. So this was a very clear gain of function, and we confirmed that by luciferase assays. You can see here, I told you that IKAROS usually prevents or negative regulates the expression of genes. As you can see here, you have the empty vector, doesn't do anything. The wild type reduce it like by 60%. These 2 mutants reduce it further, another 40% compared to the wild type. So clearly it was a gain of function in terms of the activity. Here is the activity that you get with the wild type, and you have here like a 50% more activity compared to the other ones. And here you have the other mutants that we compared before, so they have no inhibitory effect whatsoever. So you can see very clearly that these guys have no activity and these have hyperactivity in terms of negative regulation of genes. Nothing was obvious in terms of the confocal microscopy or immunofluorescence. So what I have shown you so far is that 4 different mechanisms of actions can give you 4 different types of clinical phenotypes and 4 different types of tips that can help you to diagnose different forms of IKAROS-associated diseases. You have the haploinsufficiency with CVID, that the clinical phenotype are going to be at all ages. Infections are highly prevalent. Patients will have hypogammaglobulinemia of at least 2 isotypes, most of the patients. T-cell defects were mostly CD8s that they were high, but there was not a very strong clinical phenotype associated to it. B-cell cancers were seen in those patients. Autoimmune disease was seen in 5 out of 45, and asymptomatic, 1/3 of the patients were asymptomatic. Let's go to this one, the most severe form, that is the dominant negative. Now, the age of onset is not at any age. Most of the patients are symptomatic by the age of 1 year. Every patient has PCP, and it could be recurrent and having it multiple times. AGAM was highly prevalent. TH0 says that they are naive recent thymic emigrants, and TH0, all the T cells were this way. Neutropenia and eosinopenia was seen in all of them, all the patients. Hem-onc manifestations, again, were prevalent in this disease. There were no autoimmunity, no allergies. So these patients, despite of all their clinical manifestations, they do not have autoimmune of allergy disease. So this could be a very good tip in order to diagnose these patients. If you have a patient that has allergies, it's very unlikely to be this form of the disease, because these patients are kind of protected towards allergy. Again, if you have another family member that is asymptomatic and carry the same mutation, it's very unlikely to be this disease, because this is a very severe disease, and then there's no asymptomatic family members. The dimerization defects also can appear at all ages, like the CVID. So infections were not a very important part of the phenotype. Hypogam, mild hypogam, was present in approximately 40%, but again, infections were not that prevalent. No T-cell defects, no myeloid defects, but yes, a lot of hematological or hem-onc manifestations, either malignant or non-benign like TALL and Burkitt, or benign or non-malignant like ITP, autoimmune hemolytic anemia, neutropenia, or Evans syndromes were seen in approximately 1/3 of the patients. Autoimmune diseases, despite this, also highly prevalent and asymptomatic, very similar to the CVID. 1/3 of our patients were asymptomatic. And then last, it was the gain of function, the last one that I have shown you. These guys can present early, but also can present later in life. So infections, they were not the most common thing, but they were there. Hypogam, it was in one individual, but most of them have normogam or hypergam. Remember, you can have IKAROS associated with diseases with AGAM and also with hypergam. So remember, this will help you to discriminate the patients. So here, in terms of the T-cell defects, most of the patients have skewing towards TH2, and those patients had not just hypergam, TH2 skewing, eosinophilia. Very clear that was the environment was very prone to autoimmune or immune dysregulatory kind of manifestations. So hem-onc, plasma cell proliferation, was present in most of them. So remember, here there were no B cells, here B cells proliferate increasingly, and instead of having B cell BALL or Burkitt, we usually have terminal differentiation defects like multiple myeloma manifestations. Autoimmune diseases, very prevalent, allergies, very prevalent, asymptomatic. So it was 12%, but I would say that the big cut is this one, no asymptomatic. All the others, you can have individuals that they carry mutations, but they don't have clinical manifestations. So I have shown you different mechanisms of actions and different clinical phenotypes that they have their own clinical phenotype, but also their own tips to help to diagnose. Low B cells, that they are all memory B cells. T cells, that they are mostly TH0 naive. Here, you have something that it resembles CVID, but the infection disease is not the most prevalent. And here you have hypergam, eosinophilia, and hyper IgE as kind of the main feature that you can use to suspect these diseases. So we discussed about the somatic mutations that have poor diagnostic prognosis factor for BLL, and keep in mind that 1% of all the pediatric patients that have BLL, the most common cancer in pediatrics, they will have germline, but not somatic mutation. That was described by the Sanjut group when they retrospectively analyzed their BALL, almost 4,000 patients with BLL. They found that 1% of their population of pediatric BLL, they have germline IKAROS mutations. So we have the haploinsufficiency mutations that are associated with CVID. We have the dominant negative mutations that they are associated with CID. We have the dimerization defective mutations that they are associated with benign, malignant, and immune dysregulatory hem-onc manifestations. And we have the germline heterozygous gain of function mutation that they are associated with immune dysregulation and autoimmunity. And there are more, so there are patients that are associated with bone marrow failure, patients that are associated with abnormal newborn screening because they have low TREX. There are other features that they are less common that they could be associated with IKAROS mutations. But I told you everything about IKAROS. Let me give you a few hints to diagnose the other diseases that they are associated with the IKAROS group of genes. So now I told you about all this, and I already extended a lot of time doing this. Let's move to the other one, Pegasus mutations. So here, mutations in Pegasus are associated with thrombocytopenia. They don't have immunodeficiency, but they have thrombocytopenia. So if you have patients with ITP and you suspect that there's something in the IKAROS family transcription factor, the one that could be associated would be Pegasus, and also it could be the dimerization defects in IKAROS. What about Aiolos, the god of the wind? This year, we published 2 different papers associated with Aiolos mutations. So this paper that was published in Nature Immunology is describing patients with EBV susceptibility, Epstein-Barr susceptibility, that they have Aiolos mutation. And actually, this mutation that's in amino acid 159, so it was acting through preventing the work of IKAROS. It was very interesting, and those patients have benign and malignant B-cell kind of manifestation. They have infectious mononucleosis, but they also have tumors, cancers associated with EBV. And then we found another set of patients with mutations in one amino acid separate. This one was 159, this mutation 160, and in this case, the phenotype was exactly the same that our patient with dominant negative IKAROS mutations. So here, so Aiolos, it's associated also with PCP and the same phenotype that I show with the light blue manifestation. So again, clinical phenotype conducting or suggesting the genetic disease of these patients. So then we have Helios mutation. Now there are 3 papers up there. So those patients present with a CVID, CID kind of manifestations. So we just published that one, and they are associated with hypogammaglobulinemia and T-cell defects, mostly associated with T-regulatory cells that they are not working properly. The only one that we haven't tackled so far is Eos, the goddess of dawn or aurora, that probably, so we haven't found patients associated with Eos mutation because probably it's pretty redundant. If you study the mouse model of Eos, so those mice, they have no clinical manifestation. So probably this is the reason why we haven't found so far patients with EOS mutations. We have found all the other genes associated with the IKAROS family transcription factors, but EOS probably is so redundant and could be covered by the other ones. That's why there are no patients yet associated with EOS defects. So let me thank the partners in crime that we work together on this project. So mostly Hazen Quen in the lab, that she led most of these studies, and everybody in the lab. So the people at the Rockefeller University and Necker, Bertrand Boisson, we work together on the CVID phenotype with Mary Ellen Conley and Jean-Laurent Casanova. So then David Budbul and Akihiro Oshino in the team of Sylvain Latour, we work with them on the dominant negative and also the gain of function mutants. And here is the team that we work on the IKAROS mutation at the Tokyo Medical and Dental University in Tokyo, Motoi Yamagita at Tomohiro Morio's group, and Jingji Chang at Ichiro Taniguchi group. So Ichiro and Jingjie were the ones that they prepared the mouse model for the IKAROS. So we worked together with both of them in the two IKAROS papers, and with Tala Shaheen and Kan Boksud, we worked together on the Helios defects. And then I want to thank all my other colleagues in Cincinnati, in Wisconsin, in Florence, in New York, in Colorado, in Utah, in Atlanta, in Nagoya, Japan, in South Carolina, in North Carolina, Mayo Clinic, North Carolina, Virginia, so University of Tennessee, Germany, München, Johns Hopkins, Georgia, Texas, Colorado, Zurich, France Marseille, Norway, and Utah, that all together were able to put together this data that help us to diagnose and try to help clinically our patients. So without any else to say, so now we are open to questions. Thank you very, very much.
Thank you, sir. So to begin the panel discussion, I request Dr. Aruna to ask her questions.
Yes.
It was a mind-blowing presentation, sir. It shows the years of work put into this. It's something new for me. I went through this yesterday only, just prior to this talk. But I definitely, I diagnosed the clinical phenotypes. I'm a pediatrician. I do hemato-oncology. So we diagnose the clinical phenotype as combined immunodeficiency. We diagnose them as EVANS. We diagnose them as leukemias, lymphomas. But this is something more of a molecular basis for the disease phenotypes. So my first question is, how to will next generation sequencing reveal this diagnosis? If I send NGS, will it show me the diagnosis?
So thank you very much, Arun. This is a very important question. So I get that somebody's not that happy with my answer. Somebody's shouting there. So it's fine. I have kids too. So we work at the research facility. So we collect from every patient. So in our case, it's kind of an unbiased approach. And that's why we're able to find patients that have a CVID phenotype. And it's not that we stuck with a CVID phenotype. So every patient that we receive, we collect some, because we know that if we don't do that, we will be missing the dimerization defective, we'll be missing the gain of function, because clearly they do not fit into the clinical phenotype. So at our end, we wanna collect from everybody. But let me tell you something that might be interesting, not sure about in India, but in other parts of the world. So I don't know if you are collecting most of your primary immunodeficient patients or you are doing panels. Keep in mind that there are several panels that they do not include IKAROS. So for example, if you go to the most common panel in the US, the Invitae, it doesn't include IKAROS. Why? Because it has too much homology to other genes, and they don't want to get genes that they're too homologous, because it could be confusing for them. So that kind of could be dangerous somehow, because you might think that you have done a panel, and because IKAROS was not picked up, the patient might not have IKAROS. You have to check about your panels if they include the genes of your interest. So the most common panel that we use in the US, it doesn't include IKAROS for reasons that they're beyond our control. So in terms of your particular question, which are the ones that they're gonna develop cancer? So we are not there yet. We actually, but we consider that because the prevalence of cancer in our patients is between 15% in most of the allelic variants versus a 40% in the dimerization, we say you have a risk for a hematological cancer. So that's why we suggest our patients to undergo bone marrow transplant, because we know that it rescues them. So I think that a 15 to 40% chance of developing a hematological cancer is a pretty good reason to, if the patient have a good donor, is in a good condition, to transplant them. because transplants have shown to cure the disease and to prevent the occurrence of hematological malignancies.
Thank you. That was
Thank,
explanatory.
thank you, ma'am. So we have a relevant question asked by Dr. Amit Rao from PGI. So how common are these intergenic deletions, and would they be picked up on NGS?
So which question is that one?
So the in the Q&A it's the first, and in the chat it's the last.
Okay, please, will I repeat the question, because I was trying to pay attention to it.
How common are the intergenic deletions in the IKZF1, and would they be missed on NGS?
So I cannot tell you about frequency. I know that we found them. So, but then it's a matter of whoever does your NGS studies, if they are doing copy number variation, yes or no. So with the intragenic deletion, it might be very difficult to detect. So, but it was detected by whole exome sequence. For sure, it's going to be detected by whole genome sequence, but we all know that that's kind of not the common approach. But if you do a microarray, a good quality microarray, or you do a copy number variation in silico, you might detect it. Actually, our intragenic deletion was detected by in silico, the one that can be done in the computer, copy number variation analysis. So whenever you do NGS studies, either panels or whole exome sequence, be sure that you're running a copy number variation analysis, because you might find intragenic deletions. I would not say that it's the most common. I would say that the most common mutations, as in general, are the single nucleotide changes, but you know, we know that they do exist. But don't rely on that as the most common one. So it's rare, but it could happen.
So, Dr. Vijay, ma'am, you have questions?
So here,
thank you, Dr.
I have,
Sergio.
yeah, please go ahead.
Yeah, thank you. That was a wonderful presentation. I was just wondering, looking at the Evans plus phenotype and the clinical spectrum of IKAROS, should we actually reinvestigate all the patients whose NGS was sent way back in, say, around 2012, 2013 to 2016, 17, and look for IKAROS? Because I'm sure when we were doing the PIT panel, IKAROS was definitely not covered.
So I would say that it's going to be a good policy. I would not say that this is going to be as prevalent as COVID. So don't get me wrong. It's not that you have one COVID patient, one IKAROS patient. It's not that. But if we don't look deeply, we will miss them. So you decide which are the patients that you want to privilege, or the patient that, but if you have patients that they have PJP multiple times, go there. If you have patients, all naive cells, go there. If you have patients that have progressive B cells decline, go there. If you have patients with multiple myeloma and kind of a hyper IgE immune dysregulation phenotype, you can think about it. But again, this is not a common disease. I'm passionate about it, but I am also realistic. So if you study 100 patients, you might find one or two, but you know, you'll find one or two. So what I mean is, it is there, is not, you know, is not high blood pressure, is not diabetes, is not obesity, but is there. And if we don't look at it, we'll miss them 100% of that.
Thank you. Thank you so much.
Thank you, ma'am.
So there's another
Yes.
question, Umair, about SAGAR, indication for BMT and IKAROS related. So
Yes.
let me take that one, because I think that this is important. So among the patients with the dominant negative, the most severe phenotype, among the world population of patients that they carry that mutation, 50% were transplanted before we had the genetic diagnosis because of the severity of the disease. So what I mean is, those patients are transplantable and they are rescued by the bone marrow transplant. So then you can check about the donor and the conditionment regimen and whatever you use, but HACT rescue those patients. And I think it's a very good idea, because you not just rescue the infection risk, you also rescue the cancer susceptibility risk. So I will not say that every patient with CVID should be transplanted, but keep in mind that approximately 15% or approx of these patients are gonna develop at some time some kind of hematological disease. So consider it for the most severe cases, not for all the cases. Certainly for the patient that have the dominant negative mutations, we strongly advocate for them to be transplanted because we think that they're going to succumb to infectious diseases or to cancer if they are not transplanted.
Dr. Meena, ma'am, your questions?
Thank you, sir. That was a wonderful presentation. I was aware about somatic mutations can cause BALL, but this was new to me. When I got the invitations, only come to know about these mutations. I was, as Arna ma'am said, I was going through this literature of your paper yesterday only, sir. This we have couple of cases with the BALL, which was later on turned out to be, after completing the chemotherapy, persistent to have autoimmune hemolytic anemia. That phenotype is similar to you. It's a low borderline B cells and hypogam, but we could not pick up any mutations. Genetic mutations came out to be negative. We end up sending with clinical exome sequencing. After this, what investigations further we need to do to diagnose these kind of difficult cases?
So no, I 100% agree. So what we do, and that's another tip that I will give you. So for us, so before, in order to try to rule out somatic versus germline, we used to grow fibroblasts. You know, it was the good approach, but it was cumbersome. It was not easy. Not everybody has the possibility of growing fibroblasts. Now we go for nails, just the nail, no blood. With one nail clip, we can extract DNA from nails, not the finger, not the skin, just a nail clip. We extract DNA from there. This is non-hematopoietic tissue, and we're able to discriminate the hematological or hematopoietic compartment versus the non-hematopoietic compartment. So in case of your patients that you have and you suspect that they are somatic, you can wait until they recover and see if the mutation disappears when the malignant clone disappears, but also you can check for nail clips. One nail clip is enough to do whole exome sequence. I can send you the protocol. It's a commercial protocol, and you extract enough DNA. And you know, that has the beauty that you don't have to go through customs or whatever. So you put just a nail clip in an envelope, and then you extract DNA from there. And actually, we do that from those patients that are from far away, and we cannot get blood. So because that's going to be kind of a genomic DNA kind of extraction, and it's pretty reliable and a pretty good source of DNA. Okay, no nail polish. That's the only request. So please ask your patients not to have nail polish because that's going to interfere with the process. But besides that, so if you want to discriminate hematologic or hematopoietic compartment versus non-hematopoietic, so fibroblasts are kind of the gold standard. Nail clips are a very good source of genomic DNA to discriminate one from the other one.
And if any child with BALL, if you're doing gene panel, if they are found to have IK set of mutations, whether we need to look for underlying germline mutations and whether that is the indication for HSCT in those children. For all those who have these mutations, whether we need to look for it.
Exactly, and this is what the people of St. Jude have done, and what they found exactly is that 0.9% of their 4,000 something population of BALL, they have germline mutations. So yes, there are some that they do have the somatic, that it was known before, but among those, so there were some that they have germline mutations. And interestingly enough, the mutations were neither at the DNA binding nor at the dimerization. They were somewhere in the middle. So there are other things that IKAROS can do that might be associated more with cancer susceptibility rather than immunodeficiency. If you have mutation in the DNA binding or the dimerization, it's going to be probably immune deficiency, immune dysregulation. And if you have it somewhere in the middle, it's going to be probably only BLL. I don't want to be categorical, but this is what we see. The patients have mutations, DNA binding, dimerization, they have immunodeficiency, immune dysregulations. The one that they're in the middle, probably they might have BALL, and that's going to be the only manifestation. Might, but we don't put our hands on fire for that. So we said, okay, everybody has to be tested.
Thank you, ma'am. And Grace Subramanian, sir, your questions.
You said many of these patients were transplanted even before the diagnosis was made. And was it possible that some of them were transplanted from a related donor who was asymptomatic for the same mutation? Did it ever happen?
Unfortunately, yes. But okay, this is a sad and happy story. So one of the patients that had the CVID phenotype, the patient had a BALL. So his asymptomatic brother that was HLA identical was a source of bone marrow for the patient that had a BALL. So the patient was transplanted with his brother. He completely reconstituted. So the effect of the graft versus leukemia worked perfectly fine. The patient perfectly recovered, but then we realized that the brother was also a carrier of the mutation. But at that time, so he had B cells, he had normal immunoglobulins, and the bone marrow reconstituted in his brother. So it's very interesting that unfortunately, because we didn't know the disease, so one guy, so the patient had BLL, had hypogam, was affected, and his brother was completely unaffected clinically, but they carry the same mutation. Unfortunately, we have done that experiment. So it's not that we have done, so the medical community have done it. And it worked for the bone marrow, and it worked to reconstitute, to fight the leukemia and reconstitute the bone marrow. But it's not something I'm gonna recommend, obviously. But yeah, because of ignorance, we have done it and it worked. So it rescued the leukemia, and the patient rescued and grafted and rescued his bone marrow. How long the patient gonna be with B cells and normal, I don't know. We know that there are patients that have this mutation, the same mutation, and they have been healthy until the age of 60. I have no idea what happened, but no, it's not a recommended experiment to do.
Thank you.
You're welcome.
Thank you. So before we take the questions from the chat box, I have a question. The dominant negative, the haploinsufficiency one, and the gain of function one, most of the mutations, they are in the DNA binding domain. Now, with the overlapping phenotype of the of autoimmune manifestations, how important is it to validate these mutations functionally? Like we can do the immunophenotyping aspect and of course the proliferation part, but the functional studies that you've done, the blotting and the confocal ones, how important is it to induce the mutation and check?
It depends, it depends on what do you want to do. If you want to treat the patient, if the patient is hypogam, you don't need anything else to be done. If you want to give family advice or genetic counseling, you might want to test a little bit more. So we have tested a lot of mutation. I'm gonna appeal to the people that they're working on the field. So because probably we have tested some of those mutations, so we can help you in silico, said, oh, we already did it, or we can put it in our system and do it. So if there are different layers, if you want to treat your patient, you have to treat your patient. If you want to transplant, probably you will need a little bit more. So if the patient is so severely ill that needs to be transplanted, yeah, you have to be transplanted despite of whatever the patient has. But what I mean is different layers of things. So if you want to publish it, obviously you will need some validation. But the first step I would suggest is contact people that they're working in the field, and we can try to help you.
Thank you, sir. So Amit Rawat sir, he has one more interesting question I also wanted to ask. The somatic variants in the IKZF1 are found in BLL, whereas the germline variants lead to TLL. Also, you had said that in the mice, it leads to TLL. So why is this paradox?
So I can go pretty easy. Humans are not mice and mice are not humans, but we have found both B defects and also T cell defects in humans. So we have TLL in humans and we have a lot of B cell defects. We believe that IKAROS is more relevant to B cell maturation than to T cell maturation. And that's kind of an obvious conclusion. So there might be some other redundant factors that could prevent hyperproliferation of T cells that in B cells, IKAROS seems to be more relevant. But we have seen both. We have seen B cell malignancies and also T cell malignancies. More B than T, but we have seen both.
So, what do you consider a normal range for Tregs? And do you determine using surface markers, or you do for P3 also?
So that's an interesting question, because so let me go again to the both extremes, the dominant negatives and the gain of function. both of them have no Tregs or very low Tregs. But while these guys are protected towards autoimmunity, they have super autoimmune phenotype or environment here. The patient with the dominant negatives, they do not have Tregs, that's right. But they lack B cells, they lack plasma cells, they lack immunoglobulins, they lack eosinophils, they lack IgE. So yes, they don't have Tregs, and then the T cells, they have no effector or memory function. So yes, you have no Tregs, but then you don't have cells to control because they are not there. So I guess that the Tregs in the dominant negative, despite you suspect, okay, if you have no Tregs, you have a more autoimmune immune dysregulation environment. These guys, they do not have it because they lack the effector cells. They lack the immunoglobulins, the B cells, the plasma cells, the eosinophils. So the IgE, everything that makes the final effect is not there. On the other hand, the ones that have low Tregs and they have a lot of B cells, a lot of T cells, a lot of immunoglobulins, clearly those guys, the Tregs might have a real role in not controlling some cells in order to exert some kind of clinical manifestation. So you can use the Tregs, but it's not a very neither sensitive nor specific. Besides, the tests for function of Tregs are not very reliable, and this is on the voice of Rosa Baqueta and the people that they work on Tregs. They say, yeah, every functional test for Tregs is not super reliable. So just relying on the numbers, unless they are zero, so there's not too much to say.
And are there other genes that modify clinical expression of IKAROS, resulting in different outcomes in different peoples, asked by Dr. Sagar Bhattad? So are there any other genes that modify the expression?
Absolutely. So there are different genes. So we have done expression and we have done, so RAC modifies, RUNX1 modifies. So it's a super promiscuous gene that it's absolutely interconnected with many other transcription factors that they regulate each other. So the whole family regulates each other, interact with each other, and other genes associated with T and B cell maturation could also control. Cereblon, it's well known to be, cereblon is associated with the degradation. So whenever we use leflunomide, so the thalidomide analog, so what you're promoting is the degradation of IKAROS. So there are multiple genes that they are associated with IKAROS regulation. And we're working on some of them because we have patients that they have very similar phenotypes that the IKAROS patient, and they don't have any mutation in the IKAROS family transcription factor. But keep in mind, IKAROS interacts not just with Aiolos, with Helios, interacts with IRF4, interacts with CTBP1, interacts with many other genes that they regulate themselves at the genetic level, but more importantly at the protein level.
Thank you, sir. Those were the questions from the chat box. Also, sir, which whole exome sequencing kits do you use for the whole exome sequencing library preparation? Do you use a custom library preparation or?
So it doesn't matter. So as long as it's clinically validated or it's scientifically validated. So we have used different platforms and different kits in order to use it. So as long as it's a validated system, I would say that it should be okay. Okay. So it's your sensitivity and your specificity going to tell you what you're finding. So if you're finding everything is there, and if what you're finding is real, but no. So you know that most of the people now are using the Illumina platforms, and I would say that most of the kits that they feed the Illumina platform, they do work.
Okay. Thanks, sir. So one more question. So does leflunomide work in IKAROS gain of function?
So sorry, I said leflunomide is lenalidomide. So sorry, it was my mispronunciation. Lenalidomide, the thalidomide analog. It's not leflunomide, lenalidomide, the thalidomide analog. Sorry, Amit. So sorry, my mistake. It's not leflunomide, lenalidomide, the thalidomide analog that is used for multiple myeloma.
Does it work in these gain of function patients?
No, we tried and it doesn't. We loved it. We loved it because it could have been perfect. And we tried it. And in vitro, it semi-worked, but we tried them clinically and it doesn't work. Or at least in the single patient that we tried. So there was a patient that we wanted to transplant, and while we're waiting for the transplant, we treated the patient with lenalidomide, and it didn't work. So sorry, Amit, I have to correct myself. It's not leflunomide, lenalidomide, and in vitro worked, but in vivo in the patient, it didn't work. But it was a very interesting approach. We're so enthused, and despite of our good vibes, and no, it didn't work. It didn't work as we wanted, and the patient had to discontinue because of side effects. So,
thank you, sir. I believe most of the questions are covered. Thank you for the wonderful session and for answering most of our queries. And we hope to see you physically soon.
me too. So and remember, CIS meeting
Yes.
next year, March 31st, April 3rd, Charlotte, North Carolina. Will be waiting for you with open arms.
Thank you, sir. Bye, sir.
Thank you very, very much for the invitation, and thank you very much for your attention. Thank you very much.
Thank you
You're
so
most
much.
welcome, sir.
Bye-bye.